Welcome to this second lecture on the neck triangles. In this particular lecture, we are going to look at the anterior neck triangles, and specifically, we are going to look at the infrahyoid anterior neck triangles. Just to put into perspective, this is just to remind you that we decided to look at anatomy of the neck triangles in three parts. The first part, which we've already done, we looked at the posterior neck triangles. This is the second lecture we're looking at on neck triangles. The third one will come where we are going to look at the anterior triangles, but now the suprahyoid neck triangle specifically. Again, just to put into broader perspective, remember we are just doing a series on the topographic anatomy of the neck, and so this is our session 5. The neck triangles fall under session 5. We've had a series of lectures before. Again, just a reminder, the neck extends from the base of skull and inferior border of the mandible all the way to the level of the thoracic inlet, the level of the clavicle, and the scapula. The skeleton of the neck consists of the cervical spine, which is basically C1 to C7 cervical vertebra, the intervening discs and joints, as well as the ligaments. Remember, the key joints, the craniovertebral articulations consist of the atlanto-axial joint and the atlanto-occipital joint. Other than the bones, other than the cervical spine, we also have the hyoid bone, which is located in the anterior neck. We also have the laryngeal cartilages, and perhaps some osseous elements at the base of the skull are important landmarks when you talk about anatomy of the neck. We've already talked about these skeletal components when you looked at the posterior neck triangles, and so we will not revisit them in this particular lecture. It's also a good reminder to note that the neck is a useful passage for a number of neurovascular structures which are designed either to go to the thorax or to come out of the thorax, to go to the skull or to come out from the skull, and to go to the upper limb or to come out from the upper limb. Some of them will remain in the neck, definitely. And so there are several neurovascular structures that we come across when you look at anatomy of the neck. Apart from neurovascular structures, we also find some parts of the respiratory system. For example, the larynx and the trachea within the neck. We also find some parts of the digestive system. For example, the pharynx and the esophagus are within the neck. And some endocrine glands in particular, we have in mind the thyroid and parathyroid glands. For the sake of description, and also for clinical purposes, the topographic anatomy of the neck is best described in terms of triangles and also spaces. And we put more emphasis on the spaces when you want to focus on cross-sectional anatomy of the neck, but we put emphasis on the triangles when you want to look at the clinical anatomy in terms of palpation or even inspection and during operation. Generally, the neck triangles are divided using the sternocleidomastoid into two. So we have the anterior neck triangles, which are in front of the muscle sternocleidomastoid, and the posterior neck triangles, which are behind the muscle sternocleidomastoid. The posterior neck triangle is further divided by the inferior belly of omohyoid into two. We have the occipital triangle and the supraclavicular triangle, which is also known as the subclavian triangle. These triangles are the ones we focused on when you looked at the first lecture on neck triangle. So we've already covered occipital triangle, supraclavicular triangle, and remember in that lecture we also covered the suboccipital triangle. Now attention is driven to this particular region, the anterior neck triangle. The anterior neck triangle is further divided using the superior belly of omohyoid, the digastric muscle, and the stylohyoid muscle into 4 triangles. We have the muscular triangle here, the carotid triangle there, the digastric triangle there, also known as submandibular triangle, and the submental triangle there. So with that in perspective, I can give you the objectives of this particular lecture. We are going to now look at the boundaries and subdivisions of the anterior neck triangles. Then we will focus only on the anterior neck triangles which are below the hyoid. So this will be focusing on 2 key triangles, the muscular triangle and the carotid triangle. Those are the ones which are infrahyoid. The submental and submandibular will be discussed under suprahyoid neck triangles. One of the things that we find in the infrahyoid neck, which is important to talk about, is the thyroid gland and the parathyroid glands. We'll talk about that in this particular lecture. We'll then look at the boundaries, contents, and clinical importance of the carotid triangle. And again, one of the things we find so much in the neck that it's important to talk about are the lymph nodes in the neck. In this particular lecture, we look at the organization and territory of drainage of the cervical lymph nodes. We will then finish by looking at the infrahyoid neck spaces. Remember, this is more emphasis on cross-sectional imaging of the neck. Let's begin with the first agenda, which is to look at the boundaries and subdivisions of the anterior neck triangle. We can say that the anterior triangle of the neck is bounded by the anterior border of sternocleidomastoid muscle posteriorly, the midline of the neck anteriorly, and the inferior border of the mandible superiorly. So those are the boundaries of the anterior neck triangle. As we've mentioned, we subdivide the anterior neck triangle using the superior belly of omohyoid, which is this one, the 2 bellies of digastric, which is that one, and the stylohyoid muscle, which is that one. With those, we divide the anterior neck triangle into the following. We have the muscular triangle. Other than the muscular triangle, we also have the carotid triangle, and these 2 are the infrahyoid anterior neck spaces that we're going to look at in this lecture. But we also have the digastric triangle, which is this one, and the submental triangle, which is that one. Okay, these are the images that shows us the anterior neck triangle as well. So this is the muscular triangle. This is a carotid triangle. This is the submental triangle, and that's the digastric triangle. So that is how the anterior neck spaces are divided. Anterior neck triangles are divided, or rather those 4 triangles, and we are focusing on muscular and carotid triangle. Let's look at now the muscular triangle of the neck. Before we go deep into the muscular triangle, let's talk about some superficial structures which are hovering around the muscular triangle. These superficial structures, we mentioned them when we discussed the posterior neck triangle in the previous session, but no harm in repeating. We have the anterior jugular veins, usually arising near the level of hyoid bone or just above it from the confluence of submental veins. The anterior jugular vein descends in the anterior neck between the midline and the anterior border of sternocleidomastoid muscle. So this is the anterior jugular vein. As they descend, the right and the left one usually unite somewhere low, and that point of union of the right and the left one is what we call the jugular arc, usually just above the manubrium of the sternum. The anterior jugular veins may terminate either into the external jugular vein or into the subclavian vein. So these veins are in front, and so the superficial structures as well over the muscular triangle. You can see that image again, capturing the anterior jugular vein with the jugular arc. The other structure, which is also superficial in the over the muscular triangle, is the transverse cervical nerve, C2, C3. The transverse cervical nerve is also called the anterior cutaneous nerve of the neck. Remember, it is one of the superficial branches of the cervical plexus, but this one crosses from behind, crosses the sternocleidomastoid, and has divisions which span the anterior neck. So other fibers go up, other fibers in the middle, other fibers go down. So generally, we will find them, the terminal branches of the anterior cutaneous nerve of the neck, over the skin of the carotid triangle, as well as over the skin of the muscular triangle. And so these superficial structures we mentioned will also be found over the skin of the carotid triangle. We will therefore not repeat them when we look at carotid triangle, but understand that they span both triangles. Having talked about the superficial structures of the muscular triangle, we can now talk about the boundaries of the muscular triangle. So this is the muscular triangle. What are its boundaries? We have the superior belly of omohyoid there, forming that particular boundary there. We also have the anterior border of the inferior part of sternocleidomastoid muscle, forming that boundary there. And lastly, we have the midline of the neck. So midline will form the medial boundary. Superior belly of omohyoid will form the superolateral boundary. And the anterior border of sternocleidomastoid will form the inferolateral boundary. That's the muscular triangle. There's a reason why it's called the muscular triangle, because it houses the infrahyoid muscles. Now, that term infrahyoid muscles refer to the muscles which are usually below the hyoid bone. And there are 4 key muscles that are below the hyoid bone, starting with the omohyoid itself. I have starred omohyoid because although it is an infrahyoid muscle, remember omohyoid is actually a boundary of the muscular triangle, as opposed to being a content of the muscular triangle. But it is important to mention omohyoid as we mention the other infrahyoid muscles, which are also known as the strap muscles. So this is this omohyoid. This is the sternohyoid, so from the sternum to the hyoid. We have the sternothyroid, which means from the sternum to the thyroid cartilage. And lastly, we have the thyroid from the thyroid cartilage to the hyoid bone. Those are the 4 muscles which constitute the infrahyoid muscles. Apart from the infrahyoid muscles, there are some structures which are very closely related with the muscular triangle. These are the visceral structures in the neck. And importantly here, deep to the muscles that we've talked about, we find the thyroid gland deep to them. We find the trachea, we find the esophagus. Even some parts of the larynx are also found within here. And so it is for this reason that I've chosen to also discuss the thyroid gland at length during this particular session. The other visceral structures, that is trachea, larynx, esophagus, pharynx, will be discussed later when you look at the midline structures of the neck. But thyroid and parathyroid will be discussed in this particular lecture. Before we discuss the thyroid and parathyroid, perhaps we say something more about the infrahyoid muscles, which are also termed the strap muscles. So the infrahyoid muscles or strap muscles are in two layers actually. The superficial layer is the one that is made up of the omohyoid muscle and the sternohyoid muscle. So these two are superficial strap muscles. But we also have the deep strap muscle. This refers to the sternothyroid, which is this one, and thyroid, which is that one. This image captures for you that again. This is sternohyoid. That is a omohyoid. Then we have, okay, this is still sternohyoid. And this is omohyoid. Then we have the deep ones, like this one. This is sternothyroid muscle there. And the thyroid is hidden somewhere there. You're not seeing it quite well. The nerve supply to the strap muscles are the branches from the ansa cervicalis. Remember, ansa cervicalis represent the deep branches of the cervical plexus. The ansa cervicalis usually form a loop in front of the internal jugular vein. The term ansa means loop. This loop has a superior root that come from hypoglossal nerve and the inferior root that come from C2, C3. So this ansa cervicalis is the one that supplies the strap muscles. The actions of the strap muscles generally lead to movement of the hyoid bone as well as movement of the thyroid cartilage. And these occur when you're chewing, when you're vocalizing, or when you're swallowing. Perhaps this also shows you the same muscles. So this is the superior belly of omohyoid, and this is sternohyoid. Then these are the deep ones, sternothyroid and thyroid. When you look at omohyoid, sternohyoid, and thyroid, we can note that if they contract, they lower the hyoid bone. So they depress the hyoid bone. However, you notice also that thyroid, this one, will actually elevate the larynx. So if the larynx is here, this is the larynx. Remember, the thyroid cartilage is the location of the larynx. So the thyroid will elevate the thyroid cartilage, which means elevate the larynx. But sternothyroid will depress the larynx because it will pull the thyroid cartilage down towards the sternum. So sternothyroid depresses the larynx while thyroid elevates the larynx. Omohyoid itself, when it contracts because of its close relationship with the internal jugular vein, the contraction of the internal jugular vein helps to empty the internal jugular vein into the superior vena cava. So it helps in venous return. Those are the actions of the strap muscles, and that brings me to the third agenda of this particular lecture, talking about the thyroid and parathyroid glands. We'll start with the thyroid gland, and in terms of its location, the thyroid gland is this one, located in the anterior lower neck in front of the trachea. The thyroid gland is enclosed by the mid layer of the deep cervical fascia. Now, if you do remember, I told you that the deep cervical fascia has 4 components. The first one, the investing layer, is the one we are calling the superficial layer of the deep cervical fascia. The second one that we call the pretracheal fascia is what we are calling the mid layer of the deep cervical fascia. This mid layer of the deep cervical fascia, the pretracheal fascia, is also called the visceral layer. of the deep cervical fascia. It may go with another name when we are putting emphasis on upper parts. The third deep layer of the deep cervical fascia is what we call the prevertebral fascia. And this prevertebral fascia, you can just call the deep layer of the deep cervical fascia. Now, these three superficial, mid, and deep layers of the deep cervical fascia meet around the carotid sheath. And so the carotid sheath was the fourth component of this fascial system. So having mentioned that, I'm saying here now that the thyroid gland is enclosed by the mid layer of the deep cervical fascia, which means that it is enclosed by the pretracheal fascia. This image shows you the superficial layer of the deep cervical fascia, also called the investing fascia, which encloses sternocleidomastoid and trapezius. The second layer, the mid layer of the deep cervical fascia is this one, which is going around the thyroid gland. So it is enclosing it. Well, it also encloses this region of the trachea and esophagus, but we'll talk more about that when you look at next spaces. The third fascial layer is this one here, which is the deep layer of the deep cervical fascia, and this is the prevertebral fascia. And then we have the carotid sheath, which is a union of the three around the internal carotid vein and common carotid artery. So at this point, take note that the fascia that covers the thyroid gland is the pretracheal fascia, which is the visceral fascia, or you can call the mid layer of the deep cervical fascia. In terms of gross morphology, the thyroid gland has two lobes, the right and the left lateral lobes, and we can see them here. So these are the two lobes of the thyroid gland, or in this image better. So this is the right lobe, and that's the left lobe of the thyroid gland. When you look at the shape of the lobes, they're almost conical, with an apex pointing posteriorly and more backwards. So, sorry, posteriorly and superiorly, so posterior superiorly. Vertically, the thyroid gland will measure about 5 centimeters, and then transversely and anteroposteriorly, we have 3 and 2 centimeters in terms of its measurements. So the height is the longer one. The vertical dimension is the longer one, about 5 centimeters long from the apex to the lower part. The two lobes are connected by a narrow region, which we call the isthmus. So this is the isthmus of the thyroid gland. It may be variably very narrow or very thick, or sometimes absent. This image shows you the isthmus better. So this is the isthmus, this is the right lateral lobe, and that's the left lateral lobe of the thyroid gland. Occasionally, you may have a pyramidal lobe. When the pyramidal lobe is present, it will attach somewhere here, most of the time linked to the left lobe, but it may also be from the right lobe, attaching from around the isthmus and projecting upwards towards the hide bone. This image shows you an illustration of somebody who had bilateral pyramidal lobes, but it's okay. Most of the time, it will be one pyramidal lobe, this one here. This is the left one more than the right one. That was gross morphology. Let's talk about the extents of the thyroid gland. So if you look at the lobes, the apex of the thyroid lobe extends from the level of the 5th cervical vertebra up to the level of the 1st thoracic vertebra. If you interpret that in terms of the neck structures, then the upper level correspond with the oblique line of the thyroid cartilage. somewhere there, and the inferior extend correspond to the fourth or the fifth tracheal ring. On the other hand, the isthmus of the thyroid gland rests at the tracheal rings either 2 to 3 or 2 to 4. The measurements of the isthmus are not quite much, usually less than 2 centimeters in the vertical and anteroposterior dimension. So this shows you the isthmus with the 2 lobes. Remember, the upper pole there will be at the level of the oblique line of the thyroid cartilage, and below here either 4th or 5th tracheal ring. The isthmus here extends from the 2nd to the 3rd or even 4th tracheal ring. Occasionally, you may have a thyroid gland that does not quite have an isthmus, and that is a normal variation. Now we can talk about the relational anatomy. The relational anatomy of the thyroid gland is best described in terms of relations of the lobe and relations of the isthmus. We can start with the relations of the lobes. The relations of the lobes, again, are best described in terms of surfaces of the lobes. The thyroid gland is described to have an anterolateral surface, which is the superficial surface, the surface facing us in this particular image. This surface of the thyroid gland is related to quite a number of structures. Look at this image and you'll see a number of structures lie anterolateral to the lobes of the thyroid gland. Talk about the strap muscles, in particular sternothyroid muscle, as well as the sternohyoid muscle. They are actually just anterolateral there. Also, the superior belly of omohyoid muscle, it's cut here, but again, it was also forming part of the anterolateral boundary or relationship. Then the anterior fibers of the sternocleidomastoid muscle also overlap to some extent the anterolateral surface of the thyroid gland. Lastly, we have the anterior jugular vein. They may not be very closely related because the muscles separate them, but they're still anterolateral relations. So in this cross-sectional image, we see this is the thyroid gland, so this is the anterolateral aspect. And now you can appreciate the anterior fibers of sternocleidomastoid overlapping on the anterolateral surface. We can also appreciate the presence of the sternohyoid, sternothyroid, and the superior belly of the omohyoid muscle. Even this also captures that. I forgot to mention about the anterior jugular vein. You can see they also form anterolateral relations, but muscle separates the gland from the vein. Medially, what are the relations? So medially, we are looking at this side of the lobe. The medial relations of the thyroid lobe are best described as the rule of twos. The first thing that occur in twos is that we have 2 tubes. We have esophagus and trachea. And basically, these are tubes which are on the lower aspects of the lobes. However, you can also look at the upper components of those tubes. What do you find? The upper part of the esophagus, we have the pharynx, and the upper part of the trachea will be the larynx. So the larynx and the trachea are basically still part of the tube system. Remember, pharynx and esophagus constitute one tube posteriorly. Trachea and larynx constitute the other tube anteriorly. So there are 2 tubes, but we mentioned 4 things so far. Just depend on, are we taking an upper segment? Then you look at pharynx and larynx, or a lower segment, then you look at esophagus and trachea. The second thing that occurs in twos, okay, maybe this image captures that aspect well. The upper parts will be pharynx and larynx. The lower parts, trachea and esophagus. This is the anticipated location of the thyroid lobe. The second thing that occurs in twos is that there are two muscles. We have the inferior constrictor muscle of the pharynx. So we call the inferior pharyngeal constrictor, specifically the part that we are calling cricopharyngeus muscle. And then we have the muscle, cricothyroid muscle. So cricothyroid muscle is an intrinsic laryngeal muscle. This intrinsic laryngeal muscle is usually on the outer side. We see it, and even it has its own innervation, the external laryngeal nerve, as you can see in this particular image. So those are the two muscles that are medial to the thyroid lobe. Then we have two nerves. The external laryngeal nerve that supplies the cricothyroid muscle is a branch of the superior laryngeal nerve, which is a branch of vagus. Recurrent laryngeal nerve, again, a branch of vagus, is given from the vagus nerve, depending on which side the recurrent nerve loops under aortic arc on the left or the right subclavian artery on the right. Other than the medial relations of the lobes, we can also talk about the posterolateral relations of the lobes, and posterolateral relations of the lobes are well captured here. Generally speaking, this will be the carotid sheath and its contents. So remember, the contents of the carotid sheath will be the common carotid artery, the internal jugular vein, the vagus nerve. These are the major posterolateral relations of the thyroid lobes. And then we have the relations which are close to the posterior border. Remember, posterior border of the gland is rounded. So the relations of the posterior border, we can mention two things: the parathyroid glands, as well as the inferior thyroid artery. That particular latter structure is a posterior relation of the border on the inferior aspect before it supplies the gland. Now we're done with the relations of the lobes. We can now talk about relations of the isthmus. So the isthmus of the thyroid gland can be easily described as having the following relations. There's an anterior relation, a posterior relation, a superior relation, and inferior relation. Starting with the anterior relation. So the anterior relations of the isthmus, this region, would be the still sternothyroid muscle, sternohyoid muscle, and in this case, we'll also add the anterior jugular veins. Posteriorly will be the trachea, and specifically the second to the third or fourth tracheal ring. Superiorly, we have the anastomosis between the right and the left superior thyroid artery. So that anastomosis, we can just call the superior anastomotic artery, is the one that runs on the upper end of the thyroid isthmus, that one. And inferiorly, there are some similar anastomosis. Again, we can call them inferior anastomotic arteries. This is how thyroid gland will look like. This is a drawing, but this is on the right is ultrasound image at the level of the neck, and specifically at the level of the thyroid isthmus. You see the thyroid isthmus there, and this is the lobe. So that's the left lobe. This is the right lobe. This is the common carotid artery. Let's talk about the blood supply to the thyroid gland. The thyroid gland receives two arteries which are relatively constant, and a third one that is variable. So the constant one is the superior thyroid artery, which is the first branch of the external carotid artery. The superior thyroid artery runs together with the external laryngeal nerve in some of its distance, especially when it's closer to the gland. This superior thyroid artery divides into two. We have the anterior and posterior glandular branches. And each of those branches then anastomose between the right and the left one. So the anterior glandular branches will anastomose with the contralateral anterior glandular branch, and they're responsible for supplying largely the anterior surfaces of the thyroid gland. And then posterior glandular branches will behave the same and supply the posterior surfaces of the gland. The second artery is the inferior thyroid artery, which is a branch of the thyrocervical trunk. Remember, thyrocervical trunk is a branch of the first part of subclavian artery. The inferior thyroid artery runs with the recurrent laryngeal nerve. This inferior thyroid artery divides into an ascending and posterior branches. The ascending branch and the posterior branches will be responsible for supplying the lower part and posterior parts of the thyroid gland. The third artery, thyroidema, is a variant vessel. It may come from the arteries surrounding here. So it may come from brachiocephalic trunk, may even come from the aortic arc. Those are the arteries that supply the thyroid gland. Now let's talk about the venous drainage. Venous drainage of the thyroid gland is via three major veins: superior, middle, and inferior thyroid veins. The superior thyroid vein travels alongside the superior thyroid artery and terminates into the internal jugular vein. The middle thyroid vein does not run with any artery. It also terminates into the internal jugular vein. The inferior thyroid arteries usually are multiple, and they receive veins also from the esophagus, trachea, and even the larynx, and they drain into the brachiocephalic veins. Now, there are different patterns. You may have two inferior thyroid veins, so one to each brachiocephalic vein. You may also have more than two, and most of them will drain into the left brachiocephalic vein as opposed to the right one. And you do not need to cram that one. Just remember, the superior vena cava is on the right side. Therefore, the brachiocephalic vein that must cross the midline is the left one. The inferior thyroid veins tend to be midline veins, so they'll get the brachiocephalic vein that crosses the midline, which is the left one. As this image illustrates, so the left one is the one that receives most of the inferior thyroid veins. Now we can talk about histological structure of the thyroid gland itself. We will discuss histological structure of the thyroid gland in two perspectives. We'll have the stromal tissue and the parenchymal tissue. When you talk of stromal tissue, we're referring to the connective tissue elements of the thyroid gland. So this consists of thin connective tissue capsule that surrounds the gland, and we can see the capsule here and there. This capsule has some extensions into the gland, as we can see them here. Or in this particular image, we can see various extensions of the capsule into the gland. These extensions, which we call septae, tend to divide, therefore, the gland into lobules, and you can roughly see some lobules here, separated by the septa. Like this is one lobule, that's another one, separated by the septae. What do these extensions contain? The extensions contain blood vessels, which travel into the gland from those arteries we've mentioned, and perhaps veins that drain out of the gland. This image shows you the extensions, and it also shows you some blood vessel like that one, and perhaps this one, which are within the connective tissue framework, even that's a blood vessel. These arteries will also divide even further into smaller vessels, eventually becoming capillaries. By the time we have the capillaries, they'll now be within the thyroid parenchyma itself, as opposed to most of them being on the connective tissue elements. Other than the connective tissue element having blood vessels, it also houses a lot of lymphatic vessels, and it also has a lot of sympathetic nerve plexus. Now, the role of sympathetic plexus here is believed to be vasomotor in function. So that is the thyroid gland. These are the septae or extensions of connective tissue. Then this is the parenchyma. We can now talk about the histology of the thyroid parenchyma. The parenchyma of the thyroid gland consists of lobules, which have been formed from the extensions of the capsule into the parenchyma. These lobules seem to have some ovoid to circular structures of different sizes. Look at this. This is one of them. That's another one. So these ovoid to circular structures of different sizes are termed thyroid follicle. Each thyroid follicle contains two elements. The central homogeneous material, the one which you're seeing right now, is termed the colloid material. Colloid material contain iodinated thyroglobulin, and this is the storage form of the thyroid hormones. Usually this form is inactive. This image shows you the colloid material at the center there, and the other component of the follicle are the follicular cells. Now, follicular cells represent a ring of simple squamous, simple columnar, or simple cuboidal epithelial cells. So these are basically epithelium. They have all the characteristics of epithelium. Being one layer, remember, we call this simple. So this simple squamous or columnar cuboidal epithelium will be surrounding the colloid and the whole complex, what we call the thyroid follicles. This image shows you a better view of the colloid with the ring of follicular cells, and this image shows the ones which are predominantly cuboidal. They are not so much of squamous, and they are definitely not columnar. The role of the follicular cells is actually to secrete the thyroid hormones T3 and T4. T3 is what we call triiodothyronine, and T4 is known as thyroxine. Between the follicles, which means between this and that, we have these other cells, which we call the parafollicular cells. Parafollicular cells of thyroid are the calcitonin secreting cells of thyroid gland. So that tells us the parenchymal organization of the thyroid gland. This is a follicle, that's another follicle, this is another follicle. These are parafollicular cells, and the cell being pointed there is actually the parafollicular cells. Now, parafollicular cells are also called clear cells because their cytoplasm does not stain as much compared to how the follicular cells stain. So they're called clear cells or C cells. The C there usually stands for clear cells as opposed to calcitonin cells. But yes, they're the ones that secrete calcitonin. There's a difference in terms of the thyroid parenchyma when the gland is active vis-a-vis when the gland is inactive. When the gland is active, what we see on the right-hand side, the follicular cells become taller. So they are predominantly columnar, and those have a lot of cell membrane extensions into the luminous structure, which is the colloid. Those are basically microvilli. So an active gland is very active in taking out the storage form of T3, T4. This is iodinated thyroglobulin. They are active in resolving that one. And for that reason, they'll have those features we mentioned, but also the colloid material will be very minimal when the cell is very active. And so the image on your left shows you thyroid follicle, part of thyroid follicle with the cuboidal cells as opposed to columnar, and a lot of colloid material. This also captures the same, a lot of colloid material. The cells there are cuboidal predominantly. This other one, the cells are tall and the colloid material is quite minimal. Right, so that is thyroid. Now let's talk about parathyroid glands. The parathyroid glands are located, they are small ovoid or lentiform glands that lie behind the lobes of the thyroid gland. So they're located posterior to the thyroid lobes. They may occasionally be embedded inside the gland, but most of the time they just be touching the surface. Most of the time, again, there are 4 in number. We have 2 superior and 2 inferior parathyroid glands. Occasionally, they may be more than 4 or less than 4. Each of the parathyroid gland is more tall than wide. So the vertical dimension is the one that is about 6 millimeters. The transverse and anterior posterior dimensions are less than that. The superior glands tend to be more constant. These are the ones that originate from the 4th pharyngeal arc together with the parafollicular cells of thyroid. They tend to be more constant in terms of their location. However, the inferior parathyroid glands, are the ones which tend to be very inconsistent, largely because the inferior parathyroid glands are the ones which originate from the 3rd pharyngeal pouch together with the thymus. And so in the migration path of the thymus, these glands may also be quite displaced. So we have superior and inferior parathyroid glands, as I've mentioned. Let's talk about the histological structure of the parathyroid glands. How do you know that you're looking at parathyroid glands in a histological slide? First, understand that the parathyroid glands have a thin connective tissue capsule that surround them. This capsule does not quite send thick septa into the gland, but very thin ones. And so these very thin ones which send into the gland do not quite distinctly divide the gland into lobules. And so we'll just have one ovoid cellular mass, and you don't see quite a lot of divisions inside. Important to note is that you see this ovoid cellular mass or ovoid cluster of cells adjacent to the thyroid gland. Now that we've already known that this is how the thyroid gland looks like. So when you see this highly cellular ovoid structure adjacent to the thyroid, then we know this is parathyroid. The thin septa is there, separating it even from the thyroid gland, so they're not necessarily continuous. That is how we identify the parathyroid glands. This also shows you a parathyroid gland with some connective tissue surrounding, and external to that is the thyroid gland. These are higher illustration of the same. Now, the parathyroid gland has 4 cell types that I want us to talk about. The cell that has the largest size are the adipocytes. These are the adipocytes. They're usually scattered, but they're the largest. They are fat-containing cells, so you cannot fail to miss them. They are quite obvious. Apart from the adipocytes, we have the principal cells. The principal cells are these ones here. They are perhaps the smallest type of cells here. They have very thin or little cytoplasm. These are the ones we call the chief cells, or the principal cells. They're the ones which are active in hormone secretion at the point when the SLAD is acquired. But there's another group of cells that they appear slightly larger than the active principal cells, but their cytoplasm is relatively clear, and this zone illustrates that. So we call these ones the clear cells. The clear cells are believed to be just the principal cells, which are in their inactive state. At any given time, the number of inactive cells are usually more than the number of the active cells in the parathyroid gland. And so we'll still expect to see quite a large number of clear cells. The fourth cell type of the parathyroid gland is these ones here, which have a lot of cytoplasm. They're only, they come second to the adipocytes in the parathyroid gland. We can see that they have a lot of cytoplasm. We call this one the oxyphil cells. The actual role of the oxyphil cells is not quite clear, but what we note is that the number of oxyphil cells increase as you grow older. Okay, so that was the parathyroid gland. And so that summarizes the story of the third objective, where we talked about thyroid and parathyroid gland. I want us to now look at the carotid neck triangle. So remember, this is the other infrahyoid anterior neck triangle that we're supposed to look at. The first one was muscular triangle. We can start by just reminding ourselves about the boundaries of the carotid triangle. So this is the carotid triangle. We can state that anterior inferiorly, we have the superior belly of omohyoid muscle there. Laterally, we have the anterior border of sternocleidomastoid muscle. And superiorly, which is the base, we have two muscles, the posterior belly of digastric, as well as the stylohyoid muscle. Those are the boundaries of the carotid triangle, and this is also showing us those boundaries. Now, on the roof of the triangle, we have the muscle platysma, which extends quite a big part of the neck. We also have some branches of the facial nerve, and especially the one that supply the platysma, that's the cervical branch of the facial nerve. And we also have the cutaneous branches of the cervical plexus, and in this particular case, we are specifically talking about the transverse cervical nerve, which has extensions over the carotid triangle. So this shows you the platysma as it covers over the carotid triangle. The floor of the triangle usually has the following. So thyroid muscle will be partly in the floor of the carotid triangle, but we also have the hyoglossus muscle. This is a muscle that comes from the hyoid bone to the tongue, hyoglossus. We also have the inferior and middle constrictor muscles of the pharynx. Okay, this image captures for you that. So let's consider this to be posterior, where we have sternocleidomastoid. This is anterior, where we have should be the superior belly of omohyoid muscle, not inferior, but superior belly of omohyoid muscle. And this is the roof, where we do have the posterior belly of digastric as well as the styloid muscle. So this is the hyoid bone. So the muscle that comes from the thyroid cartilage to the hyoid bone, that is thyroid muscle, is partly in the floor. The muscle that comes from the hyoid bone towards the tongue, hyoglossus muscle, is also partly in the floor. Then the middle pharyngeal constrictor, as it comes to attach to the hyoid bone, is also in the floor. And the inferior pharyngeal constrictor is also in the floor. The inferior pharyngeal constrictor arises from either the thyroid cartilage or the cricoid cartilage, and so we call it the thyropharyngeus and the cricopharyngeus muscle, respectively. This would be more of the thyropharyngeus component of the muscle, forming the floor of the carotid triangle. This image also captures for you that anatomy that we've just described. Now, what are the contents of the carotid triangle? We have the carotid arterial system, which refers to the common carotid artery. Also, the bifurcation of the common carotid artery into external and internal carotid arteries. We find that within the carotid triangle, as we can see, common carotid, internal carotid, external carotid. Other than that, we also have several branches of the external carotid artery, and we are going to look at them. And most of them are accompanied by veins, which are also contents of the carotid triangle. The internal jugular vein and its tributaries are also contents of the carotid triangle. This is the internal jugular vein. It is indeed quite a large vein. Hypoglossal nerve is partly within this particular triangle. This is the hypoglossal nerve, and as I mentioned earlier, hypoglossal nerve gives the superior root of the ansa cervicalis, which again will also be part of this particular triangle. As you can see, this is the superior root of the ansa cervicalis. It's coming from the hypoglossal nerve. We have the internal laryngeal nerve and the external laryngeal nerve, which are branches of the vagus nerve. So vagus nerve has branches which come into this particular triangle. This shows you the ansa cervicalis. This shows you the vagus nerve, which is still also a content, and its branches, the external laryngeal, which goes to the cricothyroid muscle, and the recurrent laryngeal, which supplies the rest of the laryngeal musculature. This shows you the external laryngeal nerve, which terminates at the cricothyroid muscle. It is a branch of the superior laryngeal nerve, which is a branch of the vagus nerve. The internal laryngeal nerve, on the other hand, pierces the larynx between the junction between thyroid cartilage and the hyoid bone. So that's the thyroid membrane. It pierces the thyroid membrane to enter the internal part of the larynx. So the internal laryngeal nerve will supply the mucosa above the level of the vocal cord. Also, as a content of the carotid triangle are the deep cervical lymph nodes, or otherwise what we call the jugular chain of lymph nodes. I want us to talk about the different elements of the contents of the carotid triangle one by one. We start with the carotid arterial system. When you talk of carotid arterial system, we're talking about the common carotid artery, external carotid, and internal carotid artery. We can start with the common carotid artery. The right common carotid artery arises from the brachiocephalic trunk, while the left one arises from the arc of the aorta. So they have different origin. Although they have different origin, as they traverse through the neck, they will most likely just have similar or almost similar relational anatomy. So because of the different origin, the right common carotid artery only has a cervical segment, because that bifurcation of the brachiocephalic trunk into right subclavian and right common carotid occurs behind the right sternoclavicular joint. And so after that, we just talk about the neck. However, the left common carotid artery has a segment in the thorax as well as a segment in the neck. The cervical segments of the two carotid arteries, common carotid arteries, lie within the carotid sheath, and they're accompanied by the internal jugular vein and the vagus nerves. Okay, so this shows you, okay, let me take you back there a bit. So this shows you the common carotid, the right one. And this is the left common carotid going up. Remember that common carotid is the one that will divide into internal and external carotid. Now, usually we are able to palpate the pulsations of the common carotid artery, and especially at the transverse process of C6. There's a projection there that we term the carotid tubercle. You can feel that position and becomes an important landmark for the common carotid artery, because it passes very close to the transverse process C6. Now, eventually, the common carotid artery bifurcates, usually at the level of the C3, C4 vertebra, which correspond to the upper border of the thyroid cartilage. So around this level, this is roughly the level of carotid bifurcation, although it may bifurcate slightly higher or slightly lower than that. That shows you carotid bifurcation. So we are perhaps at the level of C3, C4 junction. This also shows you carotid bifurcation into external and internal carotid arteries. Let's begin with the external carotid artery. This is the external carotid artery. So the external carotid artery arises from the carotid triangle. It is initially given anteromedially. It goes anterior and medial, not lateral, as you may want to easily think. The artery is given anteromedial to the internal carotid artery. However, it will later change that course. So that is the external carotid artery. We can classify the branches of the external carotid artery into 4. Starting with these 2 that have been marked yellow there. These are the terminal branches. The terminal branches are 2. So the one going up is the superficial temporal artery, and the one going across is the maxillary artery. Those are the 2 terminal branches of the external carotid. Then we have posterior branches. Again, posterior branches are 2. The first one to be given is the occipital artery. The second one to be given is the posterior auricular artery. So posterior auricular will supply the region of the skin behind the ear, as well as the muscle auricularis posterior and superior. The occipital artery will supply the scalp posterior to, or rather the region behind the head, the posterior scalp, but it also gives you branches to the neck. Then you have anterior branches. The anterior branch of the external carotid artery are 3. the superior thyroid artery, which supplies the thyroid gland. We've already talked about it. Lingual artery, which goes to the tongue, and facial artery, which goes to the face. In particular, the facial artery is tortuous so that it can allow the variations or degrees of movement of the neck or the head on the neck. Other than the anterior branches, we also have the medial branches. The medial branch is only one, the ascending pharyngeal artery, which goes to supply a number of things, but in particular the pharynx. We've already talked about the terminal branches being the maxillary artery and the superficial temporal artery. This is a good summary of the branches of the external carotid artery. Anterior branches are 3. Posterior branches are 2. The medial branch is only 1. And the terminal branches are also 2. That is external carotid. Now let's talk about internal carotid. Internal carotid also arises from carotid bifurcation. Then it ascends up. As it ascends up, it becomes surrounded by a lot of autonomic nerve plexus, which is from the superior cervical ganglion. Now, the internal carotid artery continue within the carotid sheath, just like the common carotid artery. It continues the carotid sheath, that it goes towards the basal skull, where it will disappear through the carotid canal. This internal carotid artery will be responsible for blood supply to the brain on that particular side, but it also gives branches which go to the eye, so supplying the eyeball itself, and might go beyond to also give you the supratrochlear and supraorbital arteries, which supply the anterior scalp. In terms of its descriptive anatomy, we can divide the internal carotid artery into segments. And historically, it has been divided into 4 key segments. There's a segment that is in the neck before the internal carotid artery enters the carotid canal. So we call that the extracranial part or the cervical part. Some people call it C1. This part does not give any branches. It is the part within the neck. Then we get to the petrous part. Petrous part refers to the part of the internal carotid artery that is now within the carotid canal. It has gone through the carotid canal and is traversing it. And remember, it doesn't traverse directly, it traverses almost horizontally. So its length within the petrous bone is quite long compared to if it was simply vertical. The arteries that come from this segment are the caroticotympanic artery, which goes to the ear, and the artery of the pterygoid canal, which is an inconsistent artery, may be there or may not be there. After the petrous part, the internal carotid artery now enters the cranial cavity and enters the cavernous sinus, and so we call that next part the cavernous part. The cavernous part will give rise to cavernous branches. These are the branches which supply the nerves within the cavernous sinus. It also gives you meningeal branches which supply the meninges, and it gives the hypophyseal branches. These are the branches which go to the pituitary gland. Lastly, we have the supraclinoid segment of the internal carotid artery, which we can also call the cerebral segment of the internal carotid artery. This one gives rise to the ophthalmic artery, which goes to the eye, the posterior communicating artery, which anastomoses with the branch from the posterior cerebral artery, we have the anterior choroidal artery, which supply many things in the brain. Eventually, the internal carotid artery divides into two, anterior and middle cerebral arteries. Now, the reason why we're discussing the internal carotid is not really because of these many parts of it, but because at least at some point it is in the neck. So this was historical, how the segments of the internal carotid artery are divided. However, okay, so let me show you that here as well. So this is a cervical segment. Before it enters the carotid canal, then this is the petrous part with the two branches. This is the cavernous part. Then after it has gone through the cavernous sinus, it comes out medial to the anterior cleaning process. We call this the cerebral part. So we can see the various branches from each of the parts. So I told you that was a bit historical. There's another classification that recognizes not 4, but 7 segments of the internal carotid artery. And it seems to be the newer classification that most clinicians would use. And so according to Gutila classification, there are 7 segments of the internal carotid artery. Segment 1 is the cervical segment. Segment 2 is the petrous segment. Now the difference comes here. Once the internal carotid artery has gone through the carotid canal, there's usually the part where now it is passing over foramen lacerum before it enters the cavernous sinus. We call that segment 3 when it is over the lacerum foramen. Remember, lacerum foramen is usually just cartilage at this point. The 4th segment is now the cavernous part when it enters or passes through the cavernous sinus. After it has passed through the cavernous sinus, it will pierce the dura mater. And, or rather it will pierce the roof of the cavernous sinus and then go slightly medial to the anterior cleaning process. And so that segment there is what we call the cleaned segment. The cleaned segment is a segment just medial to the anterior cleaned processes, and that is almost where there's a sharp turn. Then after that, that's usually a very short segment though, and it may even have a canal around it. After that, we go to what would some people call supraclinoid segment. The supraclinoid segment here would refer to segment 6 and 7, which we call the cerebral segment. This clinoid part, as well as the, or rather C3, C4, and C5, were grouped together as cavernous segment in the previous classification. All right, so C6 segment is the part that gives rise to the ophthalmic artery. Remember, this artery goes to the eyeball, or rather goes to the orbit. Finally, we have the C7 segment. The C7 segment is the terminal segment of the artery, which gives rise to the several branches which supply the brain. Okay, so this is another view: C1, C2, C3, C4, C5, C6, C7. This C4, C5, C6 segment is what is otherwise known as the carotid siphon. The way it turns, it's called the carotid siphon. This is a radiological image with contrast within the internal carotid, also showing the 7 segments of the internal carotid artery. What is important to note in terms of naming it, we just try to be able to pick what happens where. So we see from the neck, then it enters the skull. So this is the petrous part, and then this is the lacerum part. This is the cavernous part. Then we have the cleaned segment. Then That is the supraclinoid, which is giving rise to the ophthalmic artery. You can see it there. Then finally, you have the cerebral segment. Now, related to the carotid bifurcation are two important structures, the carotid sinus and the carotid body. Let's talk about these two. We begin the carotid sinus. Carotid sinus just, it appears like a swelling, a dilatation at the origin of the internal carotid. So look at this region. It's slightly bulging compared to that part. So that region of swell, slight swell, is what we call the carotid sinus. This carotid sinus houses baroreceptors, receptors which detect pressure. These baroreceptors are on the wall of the internal carotid artery. They are sensitive to blood pressure. These baroreceptors are largely innervated by the carotid branch of the glossopharyngeal nerve, although sometimes vagus has a communication here. So this shows you the carotid sinus, and this shows you the branch of vagus, sorry, the branch of glossopharyngeal, which is this one, which comes to the carotid sinus as well as body. Now let's talk about the carotid body. The carotid body, also known as glomus caroticum, is a richly innervated, highly vascularized ovoid structure in the adventitia of the carotid bifurcation. So it commonly will be between the right and left, it will be between the internal and external carotid artery, somewhere there. Or this image shows you the location of the carotid body, glomus caroticum. Histologically, we may find carotid body also having some extensions into the organ that divides it into small lobules. This organ is encapsulated and has small lobules within it. Each lobule has two key cell types. We have the glomus cell type, which is also called type 1 cell. And we have the sustentacular cell, which we call the type 2 cell. The glomus cell are the secretory cells. So they have, let me put it this way. The glomus cells are the receptor cells, although they may have some secretions, but the receptor cells, they are sensitive to chemical changes within the bloodstream. Now, the chemicals that are sensitive to will be low oxygen tension or high levels of hydrogen ion concentration or high levels of carbon dioxide concentration. In response to that, they may produce some secretions, but primarily they are chemoreceptor cells. So those are the glomus cells of the type 1 cells of carotid body. The sustentacular cells of carotid body provide structural support to the glomus cells. As I mentioned, the carotid body is highly vascularized, and so there are several vascular channels within that particular organ. Great, so that was the carotid arterial system. We can now talk about the internal jugular vein, which also runs with the carotid arterial system. In terms of its course, the internal jugular vein traverses the carotid sheath together with the common carotid artery, and at some point internal carotid artery, and the 10th cranial nerve, the vagus nerve. In terms of how it is formed, the internal jugular vein is just a continuation of the sigmoid sinus at the level of foramen magnum. So the sigmoid sinus is the one that comes and continues as internal jugular vein after it has passed through the not foramen magnum, sorry, but jugular foramen, jugular foramen. So beyond the jugular foramen, we call it internal jugular vein. Above that, it is the sigmoid sinus. Some people may consider the internal jugular vein to be formed as a union between the sigmoid sinus and the inferior petrosal sinus at the level of the jugular foramen. So you can still take that as its formation as well. But you may also consider that perhaps the inferior petrosal sinus is just draining into the internal jugular vein. So what are the tributaries? We can start with that inferior petrosal sinus. Remember, it's coming from the cavernous sinus. We have the common facial vein. Remember, common facial vein is a union between the facial vein and the anterior division of the retromandibular vein. Lingual vein also drains into the internal jugular, and sometimes you may have lingual and common facial vein joining before draining into internal jugular vein. The pharyngeal vein, which drains the pharynx, superior thyroid vein from the thyroid gland, the middle thyroid veins again from the thyroid glands, all drain into the internal jugular vein. How does it terminate? The internal jugular vein will unite with the corresponding subclavian vein. So the left internal jugular joins the left subclavian vein to form the left brachiocephalic vein, and the right one does the same. The junction between the left internal jugular vein and the left subclavian vein receives the thoracic duct. Thoracic duct drains lymph from the lower half of the body, both right and left, below the level of the diaphragm, and also from the upper left side. So this part above the diaphragm, the left side, and the part below the diaphragm, both sides. All that region is the territory of drainage of the thoracic duct. Then the right upper half of the body drains via the right lymphatic duct, which drains into the junction between the right subclavian and right internal jugular vein. So in terms of territory of drainage of the internal jugular vein, the skull, the brain, and parts of the superficial face, and a big part of the neck as well are drained by internal jugular vein. There are two swellings of the jugular vein. We call them the jugular bulb. So we have the superior and the inferior jugular bulb. The superior jugular bulb is at the origin of the internal jugular vein and just below the floor of the middle ear cavity. This swelling houses the other body, the glomus body, and this glomus body is now called glomus jugulare, similar to the functions of the carotid body. You can also call it tympanic body. So remember, it's also a chemoreceptor zone. Then we have the inferior jugular bulb. The inferior jugular bulb is present near the termination of the internal jugular vein to the subclavian vein. And this bulb is present because there's a valve just above it, which makes this to bulb a bit. Okay, so that was the internal jugular vein. We can now talk about some nerves. Within the carotid triangle, we have the 9th nerve, the 10th nerve, the 11th nerve, and the 12th nerve. We will talk about the 9th, 10th, and 12th. Remember, we talked about the 11th nerve extensively when we discussed the posterior neck triangle. So we don't want to repeat it here, but you can refer to that other lecture. Let's talk about glossopharyngeal nerve. As we do with the cranial nerves, we talk about cranial nerves extensively. We start with the nuclei of origin of the cranial nerves. So which nuclei of the brainstem give rise to glossopharyngeal nerve? Quite a number. We have nucleus ambiguous. The fibers from nucleus ambiguous have a special visceral efferent function. This simply means that the fibers from here supply muscles of the pharyngeal arc origin. The pharyngeal arc origin, the pharyngeal arc muscles that are supplied by glossopharyngeal are the third pharyngeal arc muscles. It's only one muscle, by the way, and that muscle is called the stylopharyngeus. So the fibers of glossopharyngeal nerve that come from nucleus ambiguous will terminate into the stylopharyngeus muscle. These fibers have a special visceral efferent function, branchiomotor, so to speak. The second nucleus is the inferior salivatory nucleus, which gives rise to preganglionic parasympathetic fibers, which target the parotid gland. The fibers from the inferior salivatory nucleus are therefore of general visceral efferent function. They are secretomotor to the parotid gland, but remember they are preganglionic. Those fibers will still travel through the glossopharyngeal nerve and then through what you call the tympanic nerve to the tympanic plexus. Then from there, the lesser petrosal nerve, which leaves the tympanic plexus and joins synapses at the otic ganglion. Then from the otic ganglion, we have postganglionic fibers which hitchhike on the auriculotemporal nerve for those fibers to reach the parotid gland. I hope you do remember that story when we looked at parotid gland itself. The third nucleus of origin of glossopharyngeal is the nucleus of the solitary tract. The nucleus of the solitary tract is largely within the medulla oblongata. This nucleus is of general visceral afferent function. So basically receives visceral afferents. This is where the fibers from carotid body and carotid sinus terminate. The information from chemoreceptors and baroreceptors, they terminate at the nucleus solitary tract. So nucleus solitary tract is therefore connected with other nuclei there to mediate reflexes, this chemoreceptor, baroreceptor reflexes, especially they are connected with the nucleus of vagus. The gustatory nucleus is actually the upper part of the nucleus of the solitary tract, but this gustatory nucleus has a special visceral afferent function. In simple terms, it has a taste function. So this is where the fibers for taste sensation terminate. From the posterior 1/3 of the tongue, they terminate into the gustatory nucleus. Then lastly, we have the sensory nucleus of trigeminal, and specifically, we have the spinal sensory nucleus of trigeminal. This one receives the general somatic afferent fibers of the glossopharyngeal nerve that supply a number of regions like tympanic membrane, the outer ear, eustachian tube, posterior 1/3 of the tongue, as well as pharynx. Remember, general somatic afferent, so this is basically general sensation, things like pain and temperature, even touch, are relayed by these fibers of general somatic afferent. And these fibers terminate in the nucleus of trigeminal. So these are the 5 nuclei connected to the glossopharyngeal nerve. Let's talk about the intracranial course of glossopharyngeal nerve. Glossopharyngeal nerve exits the brainstem from the retroolivary sulcus. This is the glossopharyngeal nerve. This is vagus, and this is the accessory together with that one. So this is the ninth cranial nerve behind the olive. This is the olive, is the pyramid of the medulla. So just behind the olive, we call that retroolivary sulcus, is the most cranial of the three nerves I've mentioned there. When it exits, it will pass through the cistern between the cerebellum and the medulla, so we can call that cerebellomedullary cistern, and then approach the jugular foramen. As it traverses the jugular foramen, the glossopharyngeal nerve has two ganglia. We call them the superior petrosal ganglion and the inferior petrosal ganglion, or you can call them the superior glossopharyngeal ganglion and the inferior glossopharyngeal ganglion. We can see them here. So this is the jugular foramen. This is the glossopharyngeal nerve. While this is vagus and this is accessory. So this glossopharyngeal, as you can see, it is traversing the jugular foramen, but it's actually on its separate dural sheath compared to the others. This compartment of the jugular foramen is purely for a nerve, so the pars nervosa of the jugular foramen. The other one is also for passage of the vein, so pars vascularis of the jugular foramen. Anyway, glossopharyngeal nerve has two ganglia here, superior ganglion and the inferior ganglion there. Usually, this region of the glossopharyngeal nerve, while it is traversing the jugular foramen, it sends the tympanic branch, especially from the inferior ganglion. So the tympanic branch exits the glossopharyngeal nerve before the nerve exits the jugular foramen. This tympanic branch is also known as the nerve of Jacobson. It's the one that's going to form a plexus on the middle ear. Then from that plexus, we have the lesser petrosal nerve coming out, which will then go and synapse the optic ganglion with the postganglionic fibers, which will then hitchhike on the auriculotemporal nerve. And that is how the parotid gland receives secretomotor innervation. Other than the role of the tympanic nerve that it plays on secretomotor function to the parotid, the tympanic branch also has general sensory functions, in which case we can say that the fibers within the tympanic branch also has the fibers that carry general sensations around the tympanic membrane as well as the eustachian tube. So in simple terms, tympanic branch of glossopharyngeal has both general sensory as well as parasympathetic functions. This shows you the two ganglia of glossopharyngeal and the tympanic branch coming out from the inferior ganglion to the plexus. Then from the plexus, we have lesser petrosal nerve, which goes to the optic ganglion. Remember, lesser petrosal nerve passes through the foramen ovale together with the mandibular nerve. And this one shows you that anatomy well. Now, the extracranial course of glossopharyngeal nerve, after it has exited the jugular foramen on its separate dural sheath, the nerve passes between the internal jugular vein and the internal carotid artery. Then it winds around the styloid process or the stylopharyngeus muscle, as you can see. This is the glossopharyngeal nerve. And then it will pierce the pharyngeal wall to go inside. It gives the following branches. The carotid branch is given quite early, way up, and then runs along the wall of the internal carotid, and that's the one that goes to supply the carotid body and sinus. It is also called the Herring's nerve. So that's the one with the general visceral afferent function. We have muscular branch to stylopharyngeus muscle. That's the one with the special visceral efferent function, because the stylopharyngeus muscle, the muscle of the third pharyngeal arc origin. The other branches are the pharyngeal branch, which goes to the pharyngeal plexus. The pharyngeal plexus here is made up of plexus from also vagus nerve, and these fibers are therefore with multiple functions. May have general somatic afferent function, but generally pharyngeal plexus itself has also special visceral efferent, but those special visceral efferent are not from glossopharyngeal. They're from number 10. We're going to explain that shortly. We have the lingual branches. The lingual branches of glossopharyngeal generally serve general sensations as well as taste sensation. They go to the tongue and in particular posterior 1/3 of the tongue. Lastly, we have the tonsillar branches. These are the branches that supply the tonsil, labeled 4. So those ones are of general somatic afferent. So they are basically general sensations. That was glossopharyngeal nerve. Now we can talk about the 10th cranial nerve, which is vagus nerve. We will again start with the nucleus of origin. So vagus arises from nucleus ambiguous. Nucleus ambiguous is also, as we mentioned, special visceral efferent nucleus. The fibers of vagus, which come from nucleus ambiguous, target the 6th pharyngeal arch. So basically, these are the muscles of the larynx. We also have the dorsal vagal nucleus, also known as the motor nucleus of 10. The fibers which come from here have parasympathetic function. Remember, they are preganglionic parasympathetic fibers. So this is classified as general visceral efferent function. Also, fibers of vagus arise from the gustatory nucleus. So this is basically responsible for taste. This is to mean that we have some fibers of vagus nerve that come from some taste buds. These taste buds are located around the epiglottis and pharynx. We have the sensory nucleus of trigeminal. This means that vagus nerve territory supplies some regions with the general sensation, especially from the ear, the dura mater, and the larynx. And last but not least, we have the nucleus solitary tract, which is a general visceral afferent nucleus. This means that fibers of vagus have some visceral afferents. Now, the fibers of vagus that have visceral afferent function are the ones from the aortic arc baroreceptors. So we have baroreceptors around the aortic arc. These are the ones that terminate in the nucleus solitary tract. Sometimes vagus may also supply the carotid body and sinus, and so that will still belong to this particular functional classification. In terms of the intracranial course, the vagus nerve leaves the brainstem, just like glossopharyngeal nerve in the retroolivary sulcus. Then it will go through the cistern between medulla and cerebellum, that the cerebromedullary cistern, to enter into the jugular foramen. Within the jugular foramen, there's a ganglion of vagus nerve. We call that the superior vagal ganglion or the jugular ganglion. This jugular ganglion generally houses cell bodies of neurons with the general somatic afferent function. So basically neurons with general sensation function. This shows you the vagus nerve with the superior ganglion there within the jugular foramen, as opposed to the lower one there, which is outside the jugular foramen. At this point, it's joined by some fibers, although little. It's joined by some fibers of the accessory nerve at that point. But important to note that most of the fibers of accessory join after that ganglion before the next one. Most of them will join later. Now, this segment of the vagus nerve, when it is within the jugular foramen, gives off two general sensory branches. One which goes to the meninges of the posterior craniodura, and another one that goes to the ear. We call that the auricular branch. So there's a meningeal branch, the posterior cranial fossa, and auricular branch, which is also called the Arnold's nerve. This one goes to the ear. After that, the extracranial course of vagus nerve is quite extensive. We'll only talk about its course within the neck. So after exiting the cranial cavity through the jugular foramen, we will find the next ganglion, which is now called the nodose ganglion. The nodose ganglion is the inferior ganglion of vagus, and this seems to have the cell bodies of neurons with visceral afferent function, both spatial as well as general, which means the fibers of taste and the fibers from baroreceptors now have their cell bodies in the nodose ganglion, which is also called the inferior vagal ganglion. More fibers, and actually most of the fibers of accessory nerve, will join vagus nerve just before this ganglion or on this ganglion. Now, the fibers of accessory nerve that join are actually the cranial accessory nerve fibers. Because if you remember the story about the 11th nerve, the spinal ones will come out to go to trapezius and sternocleidomastoid, but the cranial component joins number 10. Once those fibers have joined, the vagus nerve will travel together with the internal carotid and internal jugular vein, then common carotid within the carotid sheath. Vagus nerve gives a number of branches within the neck. One, we can see them. So there's a pharyngeal branch, which it gives to go to the pharyngeal plexus. This pharyngeal branch that goes to the pharyngeal plexus is the one that will have the motor functions, supplying the muscles of the fourth pharyngeal arc. Muscles of the fourth pharyngeal arc are generally muscles of the palate, muscle of the soft palate, as well as muscle of the pharynx. So these fibers of vagus supply these muscles. However, if we were to trace these fibers of vagus, which supply muscles of the fourth arc, we will trace them to actually the cranial accessory fibers, as opposed to us tracing them to the vagus nerve itself. So anyway, it is just sufficient to say that vagus nerve supplies the fourth pharyngeal arc as well as the sixth pharyngeal arc. But the truth of the matter is that if those fibers were to be traced back, most likely they'll land on the cranial accessory component. We just don't see cranial accessory after the cranium, so we talk about vagus. We have a branch that may go to the carotid body and sinus. So that is a bit inconsistent. Remember, the glossopharynx is the one that mainly supplies that. We have the superior laryngeal nerve. The superior laryngeal nerve gives rise to two branches, the external laryngeal, which goes to the cricothyroid muscle, and internal laryngeal, which enters the larynx to supply the mucosa of the larynx above the level of the vocal cord. The recurrent laryngeal nerve turns below the right subclavian on the right to go to the larynx, or below the arc of the aorta on the left to go to the larynx. This recurrent laryngeal nerve provides motor innervation to all intrinsic muscles of the larynx, except cricothyroid muscle, which is supplied by the external laryngeal nerve. Apart from that, the recurrent laryngeal nerve supplies the mucosa of the larynx below the level of the vocal cord and including the vocal cord. Then we have the superior cardiac branches. So generally, vagus nerve gives you cardiac branches as well. And the superior cardiac branches are the majority at this level. So these are the branches of vagus nerve, the extracranial branches. Beyond this, the vagus nerve enters the superior mediastinum, then posterior mediastinum to travel around the esophagus, and it will give even more branches in the thorax and abdomen to supply the visceral structures. Remember, this is why it's called vagus, because it supplies multiple structures in the body. That image just tries to show you the extensive distribution of the vagus nerve, which I believe you do already know. We agree that we not look at the cranial accessory nerve, but we look at hypoglossal nerves. Hypoglossal nerve originate from the hypoglossal nucleus, which is in the medulla oblongata. This nucleus has a general somatic efferent function because it targets skeletal muscles, which are not of pharyngeal arc origin. The muscles of the tongue do not come from pharyngeal arc. So in terms of its intracranial course, the nerve exits the brainstem between the pyramid and the olive. That groove is what we call the anterolateral sulcus. So there are usually multiple rootlets that join to form the hypoglossal nerve. Then after that, hypoglossal nerve, those fibers will join together, usually by two trunks which later join to form one trunk. They exit the cranial cavity through the hypoglossal canal. Then after exiting the cranial cavity through the hypoglossal canal, we now see hypoglossal nerve within the neck. Before that nerve exits, it will give a meningeal branch, which goes to supply the meninges of the posterior cranial fossa. Now, as to whether that meningeal branch is from vagus, the truth is that it is not. That meningeal branch that's not vagus, sorry, but hypoglossal. That meningeal branch is actually a C1 nerve that had joined the hypoglossal nerve. And so that nerve is just coming from the cervical plexus. It had already communicated with the hypoglossal nerve, so it's the one that's supplying the skin of the posterior cranial fossa. Not the skin, but dura mater of the posterior cranial fossa. So the sensory branch that hypoglossal give is not necessarily from the hypoglossal nucleus, that's the statement, but a branch from the C1. The extracranial course of hypoglossal nerve is that hypoglossal nerve will exit its canal and enter the carotid sheath. After it has entered the carotid sheath, it will be joined by cervical plexus, especially C1, sometimes C2 may also join it. And we can see that anatomy here. So we can see here the C1 fiber and perhaps C2 joining it there. So when C1, C2 join it there, the C1 fibers are the ones which go backwards to supply the meninges of the posterior cranial fossa. So that would seem as a branch of hypoglossal within the hypoglossal canal, but it's not necessarily so. These fibers of C1, C2 that has joined the hypoglossal nerve, the C1 fibers are the ones that remain, as we can see. And then at some point, they drop off. So that dropping off constitutes the superior root of the ansa cervicalis. This is the hypoglossal nerve again. So when the hypoglossal nerve enters the carotid sheath, it will then exit the carotid sheath and enter the digastric triangle of the neck. So we'll talk about hypoglossal nerve again when we discuss the digastric triangle, but maybe not in quite detail. So we'll just conclude with it here. This is the ansa cervicalis. So the superior root of the ansa cervicalis drop off from the hypoglossal nerve. We'd already mentioned the meningeal branch of the hypoglossal nerve. Remember, this one is not necessarily an extracranial branch, but an intracranial branch given at the level of the hypoglossal canal. Then you have the descendens hypoglossi, which is the upper root of the ansa cervicalis. And we also have the branches of still C1, C2, which had already joined hypoglossal, now being given off to supply the thyroid and genioid muscles. So those are motor branches. This illustration shows you that once C1 has joined the nerve and dropped off as a descendens hypoglossy, there's some fiber still that will continue to supply the two muscles, thyroid and genioid muscles. Great. The other neural element to talk about in the carotid triangle is the cervicosympathetic chain. So the cervicosympathetic chain consists of three interconnected sympathetic ganglia: the superior cervical sympathetic ganglion, the middle cervical sympathetic ganglion, and the inferior cervical sympathetic ganglion. This inferior one is also called the stellate ganglion, especially when it is fused with the T1 ganglion. The cervical sympathetic chain lie on the prevertebral fascia. The prevertebral fascia is the deep layer of the deep cervical fascia. This prevertebral fascia is behind the sympathetic chain, and this sympathetic chain is also behind the carotid sheath. So this is the sympathetic chain. You can see the internal carotid, common carotid artery there. This is the sympathetic chain. Sympathetic chain receives preganglionic fibers from the upper thoracic spinal nerves, especially T1 to T3, although this may extend up to T5. So the preganglionic fibers are the ones that come and synapse within the three cervical ganglion, from which we have postganglionic sympathetic fibers that can join the cervical nerves. They may also join other cranial nerves like vagus or glossopharyngeal, or they may hitchhike on surrounding blood vessels, for example, external carotid, internal carotid, or they may form distinct nerves, especially the ones which go to the heart. We call them the cardiac nerves. They go as distinct nerves to the heart. If you disrupt the sympathetic chain that goes to the head region, you may get Horner syndrome, which is characterized by drooping of the upper eyelid, remember, because the muscle of Muller is denervated. It will also present with the miosis, which is constriction of the pupil, because we've lost parasympathetic stimulation to the eye, which causes pupillary dilation. You may also have some ipsilateral dryness of the face because the sweat glands in that phase are no longer stimulated to produce their secretions. All right, so that is basically Horner syndrome, disruption of the cervical sympathetic chain. So the manifestations are seen largely in the head region. That summarizes the story of the carotid neck triangle. The next two objectives will be a bit quick. We will finish with them. We want to look at the organization and territory of the cervical lymph nodes. So before I give you the levels of cervical lymph nodes, maybe just to make some statement that the neck lymph nodes are divided into some anatomic levels, and the importance of dividing them into anatomic levels so that we can aid in cancer staging, as well as perhaps planning treatment, and especially radiotherapy treatment. There's some variation that exist in the nomenclature of the cervical lymph node levels. So the one I've adopted is the one that is commonly used. This is the one that is described by the American Head and Neck Society and American Academy of Otolaryngology Head and Neck Surgery. They define 10 levels of cervical lymph nodes, and I'll take you through these 10 levels. Before we learn the levels, perhaps good to know some landmarks that are used to divide them into the levels. We have the hide bone, and we particularly look at the inferior border of the hide bone. So you can see there's an imaginary line that passes at that level. We also have the cricoid cartilage. So this is thyroid. The cartilage below it is called cricoid before we get the trachea. Again, we're looking at the inferior border of the cricoid cartilage. You can see that level there marked. Then we have the medial border of the common carotid artery. Now, this would be largely intraoperative or radiological, but yes, that's the medial border of the internal carotid artery. We have the posterior border of the internal jugular vein, which is that one. So that's also a landmark to consider. The other landmark to consider is the sternocleidomastoid, both borders, anterior border as well as posterior border. They're going to be useful. And the manubrium of the sternum is also going to be useful. Now let's start with the level 1 lymph nodes. Level 1 lymph nodes are the lymph nodes which are present in the submental and submandibular triangles. So that is what we call level 1 lymph nodes. These lymph nodes tend to drain the oral cavity, the anterior part of the nose, the submandibular gland, and the soft tissues of the face, like the lower lips. Level 1 nodes are divided into level 1A and level 1B. Level 1A refers to the submental lymph nodes, which are limited by both anterior bellies of the digastric muscle. And level 1B refers to the lymph nodes within the submandibular neck triangle. So you call them submandibular nodes. Level 2, going to 4, are the ones we call the jugular chain of lymph nodes. The jugular chain of lymph nodes constitute what we call the deep cervical lymph nodes generally. These are the nodes which are around the internal jugular vein, common carotid artery. The jugular chain of lymph nodes are divided into 3 levels. We have level 2, 3, and 4. So those are 3 levels. We are using the level of the inferior border of hide bone. So the nodes above that are called the upper jugular chain of lymph nodes. These are level 2. They drain the face, they drain the 3 major salivary glands, that is parotid, submandibular, and sublingual gland. They drain the nose, the pharynx, the larynx, the ear. It's a bit extensive. They also receive lymphatic from retropharyngeal nodes, submandibular nodes, and submental nodes, which means that level 1 drain to level 2. We can divide them into 2A and 2B as well. The boundary we're using is the posterior border of the internal jugular vein. So the ones in front are 2A and the ones behind are 2B. The 2A1 also include the territory we call the jugulodigastric nodes. Now, some authorities prefer to use another landmark to distinguish level 2A from 2B, and especially during surgery, they prefer to use the spinal accessory nerve to be the one splitting or dividing the level 2A in front of the nerve and 2B behind the nerve. Level 3 lymph nodes are the lymph nodes which are in the middle region of the jugular chain. So this is the middle jugular chain of lymph nodes. So the landmark would be hyoid and cricoid, that region there. That's what we call level 3. They drain the base of the tongue, tonsils, larynx, hypopharynx, and thyroid gland. They receive efferents from level 2 as well as level 5 nodes. And they also receive from pretracheal, which is basically level 6 nodes. Level 4 nodes are the ones which are below in the jugular chain. So we call this the lower jugular chain of lymph nodes, but this level 4 also include the medial supraclavicular nodes. So again, they drain quite extensive region, the pharynx, the larynx, the thyroid gland, the esophagus. We divide them into two using an imaginary line that is about 2 centimeters above the sternoclavicular joint. So the region above that is 4A, which is specifically the lower jugular nodes, and the region below that is 4B. 4B represents the medial supraclavicular lymph nodes. These lymph node groups include the Virchow's node. A Virchow's node is usually an enlarged supraclavicular node, especially the left one, as a result of a malignancy of the GIT. Such lymph node may have traveled there through the thoracic duct. Remember, it terminates on the left. So a Virchow's node is an enlarged left supraclavicular lymph node, left cervical node, as a result of malignancy in the GIT, having spread through the thoracic duct. We have level 5 nodes. Level 5 nodes are basically the lymph nodes which are present in the posterior neck triangle. So they also drain the nasopharynx, oropharynx, the posterior scalp, and thyroid gland. We have level 5A, which refer to the lymph nodes within the occipital triangle, especially the ones around the accessory nerve and above that. Level 5B represents the lymph nodes within the occipital triangle, below the level of the cricoid cartilage. If you remember this, the cricoid, so this region here, that would be level 5B, so that above that is 5A. Some authorities consider the level 5 nodes to be level 5A and 5B only, in which case the lateral supraclavicular nodes will be part of 5B. Because remember that supraclavicular triangle is still part of the posterior neck triangle. However, there's some authorities that consider a separate level. For the lateral supraclavicular nodes, they call them level 5C. And in terms of how we get level 5C, it will be now 2 centimeters above the manubrium. So basically, the lymph node centered within the supraclavicular triangle will belong to 5C according to some authorities, or part of 5B according to some authorities. Level 6 nodes are the nodes within the central compartment of the neck. These are the nodes which are on the anterior neck. We have 6A, which tend to be a bit superficial, and 6B, which tend to be deeper. So the ones which are superficial are usually around the anterior jugular veins. The ones which are deeper are among many structures, but generally medial to the common carotid arteries. So the nodes which are here, that will be 5B. They'll include prelaryngeal nodes, the pretracheal nodes, the paratracheal nodes, also known as the recurrent laryngeal nerve lymph nodes. There's one lymph node which we call the Delphian node. A Delphian lymph node refers to a prelaryngeal or precricoid lymph node, generally a level 6A or maybe 6B. But importantly, it is located between the cricothyroid muscles in front of the larynx. So this is the position of the Delphian node. And usually when that node is swollen, it might mean that there is laryngeal cancer. Level 7 is very contentious. So according to this naming classification system that we're using, they have classified level 7 as the retropharyngeal and retrostyloid lymph nodes. This is according to this particular classification. So that region drained the nasopharynx, soft palate, tonsillar tissue, as well as eustachian tube. They have gone ahead to divide level 7 into 7A, which is retropharyngeal nodes, and 7B, which are retrostyloid nodes. Remember, these are nodes behind the pharynx or behind the styloid process. But, okay, so that shows you where the nodes are found. Remember that they're quite deep. They're not necessarily around these arteries, but they're quite deep. In terms of cross-section imaging, so we see this is the retropharyngeal nodes. So this is the pharynx, nasopharynx. So the nodes here will fall to 7A. And then this is the region behind the styloid. So this will fall to 7B. The network variations are these. Radiation oncologists use level 7 nodes to refer to the prevertebral lymph nodes. So the nodes which are just in front of the vertebrae are termed level 7 nodes, according to radiation oncologists. According to radiologists, this is very different. Radiologists call level 7 cervical lymph nodes as the lymph nodes which are in the superior mediastinum. So here, especially just retosternal there. So this is what we call the level 7 nodes. So these are radiologists. So understand sometimes the context, and this is why sometimes it's then recommended that when you're reporting, you don't just say level 7 are involved. Perhaps a description of where the node is more important than just giving that level 7, because level 7 is contentious. Most authorities actually will end their discussion of cervical lymph nodes at level 6, but I'll continue up to 10 according to this classification. We have level 8 nodes, which are the lymph nodes around the parotid region. So these are the parotid group of lymph nodes, quite extensive from the zygomatic arc anteriorly to also posteriorly we'll have the external auditory canal, then inferiorly we have the mandible. So this is the region we are calling the region of the parotid lymph nodes. The parotid lymph node therefore will include the superficial nodes, the preauricular ones. They'll also include the subparotid nodes and the intraparotid lymph nodes. They drain extensively, so they receive lymph from the scalp, the eyelids, the conjunctiva, the nose, the nasopharynx, the parotid gland, the ear, as well as the eustachian tube. Quite extensive. Then we have the level 9 cervical lymph nodes. The level 9 cervical lymph nodes are the malar and buccofacial nodes. They are a bit inconsistent, so they're not always there, but they're the lymph nodes which are around the facial vessels when they are present. They'll be lying on the buccinator muscle, and they'll be present in the subcutaneous tissues. But remember, they are a bit inconsistent. So these are level 9 nodes. When present, they drain the nose, eyelids, cheek, maxillary sinus, and buccal mucosa. Lastly, we have the level 10 lymph nodes, which are retroauricular and occipital lymph nodes. So these are the ones which drain the posterior scalp. We have 10A, which are the retroauricular nodes, which are also called the mastoid nodes, as well as the subauricular, which means below the ear nodes. And then we have 10B. 10B is actually occipital nodes, except that based on our line of reference, if you remember, if you use that hyoid bone and take it back, it will still cut across the occipital triangle. So there'll be a part of the occipital triangle that's above. And so that brings difficulty in classifying whether is it a 5A. But basically, a 10B is an upward extension of 5A, except that the line of reference cut it off. So it is above the level of the hyoid, but within the occipital triangle. Great. So those are the levels of cervical lymph nodes, quite extensive. You can take time to just learn them. But this image shows you all the location of the cervical lymph nodes in one span. Remember, the major contention is on level 7. And then also remember that the most consistent are level 1 to 6. These are the additions. So from 7 to 10, many authorities do not have them. I just chose to give you a very nice update from the latest. Right, our last agenda, very interesting, might take a few minutes, but important to note, the infrahyoid neck spaces. Before I teach you infrahyoid neck spaces, perhaps you need to understand some background. And this is the background. Traditionally, and even what we've done so far as we discuss the neck, is that we've divided the neck into triangles, and there's nothing wrong with it. These triangles are very important. When we inspect the neck, we see these landmarks. When we palpate the neck, we see the landmarks, and even during surgery, the person operating will see these landmarks. So they're very important. The challenge they have is that because of these landmarks, the neck has triangle, but these triangles span from up down or down up. They have a craniocaudal orientation. This becomes difficult to correlate with the clinical imaging that is usually done for the neck, because the clinical imaging done for the neck is usually cross-sectional imaging. It could be CT scan or MRI, but it cuts the axial plane of the neck. So it becomes difficult to correlate the craniocaudal orientation of the triangles with the images we see on CT scan or MRI of the neck. It is for this reason, therefore, that the spatial anatomy of the neck comes to play. Because this spatial anatomy of the neck now tries to describe the neck in terms of some anatomical spaces. These anatomical spaces are defined by the deep cervical fascial system. The advantage of describing the neck into these fascial spaces is that we are able now to analyze these images using CT and MRI scan images of the neck because these images are acquired in the axial plane, so we're able to analyze it easily. Now, when we talk about infrahyoid neck spaces, therefore, we are talking about the neck spaces that are below the level of the hyoid bone. So these are the infrahyoid neck spaces, the spaces below the level of the hyoid bone. And these are the ones we're going to discuss in this particular lecture. Then the suprahyoid neck spaces, we'll discuss them in the last lecture that we're going to have on the neck triangles. The infrahyoid neck spaces are 5. We have what we call the visceral space, the carotid space, the retropharyngeal space, the posterior cervical space, the perivertebral space. These are the spaces. Important to note again is that some of these spaces which are infrahyoid may continue down into the thorax, that's what we call the mediastinum, or may continue upwards in the suprahyoid space as well. So some of them could extend, some of them do not extend. Before we talk about the spaces, be reminded about the organization of the deep cervical fascia, because this organization is going to help us to understand the neck space as well. The deep cervical fascia has 3 layers, largely. The superficial layer of the deep cervical fascia is called the investing fascia. It is the most superficial, the one in blue, surrounds and encloses sternocleidomastoid and trapezius. The middle layer of the deep cervical fascia is what we call the pretracheal fascia. That term pretracheal is not liked by many people because it means that it's just in front of the trachea, which is not the truth. This fascia surrounds the whole region. So most people will call the visceral fascia, or simply the middle layer of the deep cervical fascia. You can see the red one, and that is how it runs and encloses to those regions. And then we have the third one, which we call the prevertebral fascia. Again, some people don't like the term pre because, again, the fascia goes round, so it's not necessarily pre. We can just call the deep layer of the deep cervical fascia. So you have a superficial, middle, and deep layer of the deep cervical fascia. But yes, deep cervical fascia is the one that's commonly called the prevertebral fascia. So those are the 3 major fascial systems of the neck. Remember, where they meet is the carotid sheath. So that carotid sheath is formed by part of any of those 3. So with that in mind, let's talk about the neck spaces. We'll start with the visceral neck space. So in cross-section, the visceral neck space is this region here. It's a cylindrical region that is anterior in the neck. This region that is enclosed by the middle layer of the deep cervical fascia. That space encloses the visceral structures of the neck, and that is why we call it the visceral space. It extends from the level of the hyoid bone superiorly into the superior mediastinum. So it doesn't quite go above the level of the hyoid bone. We'll not find a visceral space above the hyoid bone in the suprahyoid spaces. What are the key contents of the visceral space? We have the larynx above and the trachea below. We have the hypopharynx above. The hypopharynx is just the lower part of the pharynx that continues into the esophagus. So hypopharynx above and the esophagus below. We have the thyroid gland and the parathyroid gland themselves. We have the recurrent laryngeal nerve, which is a branch of vagus nerve that comes back. Remember, it loops under aortic arc on the left and some right subclavian on the right. We have the paratracheal lymph nodes, which are generally the level 6 lymph nodes. And you may have embryological remnants of the thyroid gland in this particular region. The embryological remnants of the thyroid gland constitute what we call the thyroglossal duct. There are some variations of the thyroid gland. The second space is what we call the carotid neck space. Carotid's neck space are these paired spaces on either side posterolateral to the visceral spaces. Remember, visceral space is just one midline one, but now carotid space are two. This is the region that is surrounded by the carotid sheath itself. Remember, carotid sheath is formed by union of the three. So this is the carotid neck space. Roughly extends from the base of skull. So this one continues all the way up to the suprahyoid space, which means when we discuss suprahyoid neck spaces, we'll still mention the carotid space. Then down, it continues all the way to the aortic arc, which means it continues into the mediastinum. Usually, although the carotid sheath may be interrupted on its upper end, especially above the hyoid bone after the external carotid has been given, that does not mean that the carotid space does not continue up. The carotid space actually continues up to the base of the skull because it continues into the internal jugular vein and the internal carotid artery. So what are the contents of the carotid space? Look at this image. This is the carotid space. The contents will be the common carotid artery inferiorly and internal carotid artery superiorly. We are making the assumption that we are looking at the carotid space all the way from the base of skull, although that will be partly suprahyoid. The internal jugular vein, the glomus bodies and sinus. So remember the glomus bodies we have here, the carotid body, then glomus jugulare, then we have the carotid sinus. The antecervicalis is also present in this space. Usually it's applied onto the sheath on the anterior wall, or rather, let me put it this way. The antecervicalis is usually applied on the anterior wall of the carotid sheath, just in front of the internal jugular vein. We have cranial nerve number 9, 10, 11, and 12, as well as the sympathetic plexus. However, cranial nerve number 9, 11, and 12 are only contents of the suprahyoid carotid space. The infrahyoid carotid space will only have the vagus nerve. It will not have number 9, 11, and 12. The sympathetic chain just lies behind the carotid sheath in front of the prevertebral fascia. But some fibers of sympathetic plexus will be within the carotid space. Last but not least, we have the jugular chain of lymph nodes. So remember level 2, 3, and 4. Level 2 is upper jugular, level 3 is middle jugular, and level 4 is lower jugular, as well as the medial supraclavicular. So those ones are inside here. Then we have the retropharyngeal space. This is the retropharyngeal space. The retropharyngeal space is the potential space that is behind the pharyngeal and esophageal wall. So behind this is esophagus, behind the esophagus, and upwards behind the pharynx. It is limited anteriorly with the visceral fascia, this one here. Remember, visceral fascia is the middle layer of the deep cervical fascia. So that's the one that limits the retropharyngeal face anteriorly. Posteriorly, it is limited by this fascia, which we call the alar fascia. The alar fascia is just, let me put it this way, that the deep layer of the deep cervical fascia has two layers in front of the vertebra. One layer is called the alar fascia, and the other one is called the prevertebral fascia. So the retropharyngeal space is the space between the middle layer of the deep cervical fascia, that one, and the alar fascia, this zone there. That's the retropharyngeal space. It extends from the base of skull, which means it goes quite high and goes all the way down to the level of the tracheal bifurcation in the thorax. So look at that. This is the retropharyngeal space, this one, extending all the way from the base of skull. Green is the visceral fascia, or the deep layer of the deep cervical fascia. And then this one is the alar fascia. So this space there is the retropharyngeal space. Downward, it can continue variably, anything between C6 up to T4 there, the point of termination. Normally, the retropharyngeal space will contain lymph nodes and fatty tissue. The lymph nodes are largely on the suprahyoid component of the space. And then the infrahyoid component of the space will have just fatty tissue. It is possible to confuse the retropharyngeal space with the two spaces, the danger area and the prevertebral space. And so I want to explain what those two are. Now look at this point. Let's start with the danger area. We've mentioned that this is the visceral fascia, and this is alar fascia, and this is prevertebral fascia. And so this is the retropharyngeal space. But this other space here between the alar fascia and the prevertebral fascia, this space there is what we call the danger area. So the danger area lies between the alar fascia and the prevertebral fascia. This danger area extends from the base of skull superiorly all the way to the level of the diaphragm inferior. Now you understand why it's called danger, because it means anything within that space can spread extensively, can go all the way to the diaphragm, can spread extensively. Look at this. So that is the danger area. We can see it extending all the way from the base of skull, going all the way down. Maybe I get another image. This is the danger area from the base of skull, going all the way down. We can't even see the lower extent because going all the way to the level of the diaphragm. Do not confuse that one with the retropharyngeal space, which actually ends somewhere there when the alar fascia touches with the pretracheal fascia there. Now, the prevertebral space is different from the danger area. The prevertebral space will be now this space here between the prevertebral fascia and the muscles of the vertebral column. That will be the prevertebral space. And that prevertebral space is actually part of the paravertebral neck space. And so for that reason, we can talk about the perivertebral neck space. So here, this is the retropharyngeal space. And behind that is the danger area of the face, of the neck. Now, it is not quite possible usually to distinguish the two spaces in common radiological imaging, and that is why most of the time radiologists will just call this one the retropharyngeal space, because the alar fascia is not discernible with the current investigation that we use, especially the CT. It's not discernible. All right, now we can talk about the perivertebral space, because we've just talked about prevertebral space. So the perivertebral space, this large cylindrical space that surrounds the vertebral column, this space is limited by the deep layer of the deep cervical fascia, which holds it tightly, tenaciously. It's very tight on this particular space. The large space, as you can see, surrounding the vertebral column and the muscles associated. In this particular image is the green one. That's the prevertebral fascia that's around the the perivertebral space, or we can call the deep layer of the deep cervical fascia. Now, based on this extension here, the deep layer of the deep cervical fascia touches on the transverse processes of the cervical vertebra. Based on that, we divide the perivertebral space into two compartments. We have the anterior compartment of the perivertebral space and the posterior compartment of the perivertebral space. The anterior compartment of the perivertebral space is the one we call the prevertebral space. So this one has the prevertebral muscles like scalenus muscles and the longus colli. Also has the brachial plexus roots, the phrenic nerve, the vertebral arteries and veins, as well as the body of the vertebrae. And then we have the paraspinal space. The paraspinal space is the posterior compartment of the perivertebral space. This paraspinal space now contains the paraspinal muscles, so the other muscles which are here. It also contains fat and the posterior elements of the vertebral bodies. Remember, posterior elements of the vertebral bodies will now refer to things like the lamina and the spinous process of the vertebral bodies. Lastly, we do have the posterior cervical space. The posterior cervical space, the one labeled 4 there, they are posterolateral to the carotid space. They are bounded by anteriorly the carotid sheath. Medially, we have the prevertebral fascia. And laterally, as well as posteriorly, we have the investing fascia. So this is the posterior cervical space. The posterior cervical space extends from the tip of mastoid to the base of skull to the level of the clavicles below. The key contents on this space is basically fat, lymph nodes, especially the level 2B and level 5 nodes. So you understand that we are now talking about the occipital triangle as well as perhaps the supraclavicular triangle at this particular point. It also contains the spinal accessory nerve. It contains some parts of the brachial plexus as well, and some parts of the cervical plexus. Okay, so that is the posterior cervical space, which is basically the posterior neck triangle. And so that summarizes the very, very long story of the anatomy of the infrahyoid neck triangles. After doing it, I feel like I should have divided into two, but sorry, it is now done. So the next session will be still on neck triangles, but now we'll be focusing on the suprahyoid neck triangles. We'll focus mainly on submental triangle, submandibular triangle, and that's when you also look at submandibular gland, and then we look at the suprahyoid neck spaces again. All right, thank you very much. We stop there for this one.